All right, we're live.
All right, good morning. This is Senate Health and Welfare. It is April 1st, and we are continuing our discussion today about bills that have come to us from the House. And we should have a little bit of time this morning, somewhere between 9 and 10, to just talk about the bills that we looked at yesterday very briefly, and then take a break, and then we'll come back to the bills that we have. And then at the end of the meeting, I hope we'll have a little time just to talk about what's coming up tomorrow. There we go. So good morning, Representative Donahue. Thank you for being here. And we look forward to hearing your testimony on the H-46. So why don't you introduce yourself for the record? And then after you've done that, we're going to go through the bill with Let's Counsel with Katie McClinn. So you don't need to dive us through the bill, but rather just the intent and ideas.
Thank you very much. Representative Ann Donahue from the House Healthcare Committee. I think a lot of time when we think about the rights of psychiatric inpatients, we think about people in the custody of the commissioner, which is appropriate because they're the ones who have their liberty interests impaired. But there are differences in the way a person who voluntarily is admitted to inpatient care is addressed that are probably much less well known. That law has not been updated in a number of years. And so this bill updates a few pieces of that law. Vermont is unique in not having any inpatient units that are not locked because of our policy of regionalizing involuntary care. And so people may not realize, if they don't have informed consent, that by asking for admission that they will be on a locked unit and may be stopped from leaving. Also, they may not realize if they were admitted involuntarily that they can apply and ask to become a voluntary patient, which may be very empowering if they are on the road to recovery. We also recently discovered that information on restraint and seclusion is not overseen by the Department of Mental Health when it involves voluntary patients. So we'd seen data for years, the retreat data, kids on the children's unit, extremely little use of restraint and seclusion. That was good to know, except it was incorrect because most children are in voluntary status. And when we asked for the voluntary data, it turned out there was significant use of restraint and seclusion. So we felt that really ought to be something that's comprehensive that the department is overseeing. And then the final piece is simply about the report that was requested 2 years ago for monitoring inpatient waits in emergency departments. And I guess we thought that that would all be solved in 2 years. So the reporting on it sunsetted, and this extends the sunset in this bill. And that's it. The Department of Mental Health and the Vermont Association for Hospitals and Healthcare both testified indirectly by email saying they were fine or at a minimum not opposed to any of these changes or updates.
Thank you. That was very clear. And unfortunately, for the pandemic gets in the way of moving forward, but now we can take this up again. Senator Hardy.
Yeah, I just had a question. I'm sorry, Ann, I haven't looked at the language yet. So waits, is it W-A-I-T or W-E-I-G-H-T? Which kind of wait are we talking about?
Yes, delays.
Delays. Okay, great. That's important.
Spend...
I was trying to figure out, are waits like restraints kind of waits, or yeah. Waits as in taking too much time? Oh. And then I see on our website we have another document from you. Were you going to tell us about that, or is it just?
No, that's for that is the copy of this year's report. Okay. That has the sunset. So just in case you wanted to refer, it's only a 4-page report, so it's not a hugely burdensome kind of thing, but it's just so that you could look at it if you wished.
Great, thanks.
Okay, any other questions for Representative Donahue? Thank you for bringing this to us and for your work on this and for your work on the think tank. That was
I
good.
will, I'll stay in case there are questions that come up after Katie.
Terrific. Yes, please do. You're welcome to do that. So unless there are other questions for Representative Donahue, we'll just turn to Katie McClinn to go through the bill with us.
Sure. Good morning.
All right.
Let me
Good
pull up the
morning.
document for you. Oh, there it is. Are you seeing H46?
Yes, we have it.
Okay,
Perfect.
great. We're literally on the same page. That's always a good sign. Okay, so the first two sections, let's just start with the first section. In the first section, there's existing language that before a person may be admitted as a voluntary patient, that person is to give his or her consent in writing on a form developed by the department, and that this consent has to include various information. And so in subdivisions 1 through 3, you're seeing changes. This is more like technical changes to make this into a list format. The substantive change comes with adding subdivision 4. So we're just breaking out the first 3 items into a list. Those are already existing law. And the fourth item is that this consent that a person who's being admitted as a voluntary patient has to understand that inpatient treatment may be on a locked unit and a requested discharge may be deferred if the treating physician determines that the person is a person in need of treatment pursuant to the definition of person in need of treatment, meaning that the person poses a danger to self or others. So that's the first item. The second section also has to do with notice to patients. So existing law dictates that the head of a hospital is to provide reasonable means and arrangements, including posting of excerpts from relevant statutes for informing patients of their right to discharge and other rights for assisting them in making and presenting requests for discharge. And the added language is, or for application to have the patient's status changed from involuntary to voluntary. So that is to be provided to patients so they know that they have that right and they have that information from the head of the hospital. The next item.
Can I ask a question here? And it would probably be for Representative Donahue, but Katie, could be for you as well. So the decision to say that sections of statute would be posted. Is that what, I don't know who wants to, how you want to.
I didn't want to delve into changing existing law, so that was all just the existing law. So this simply adds, there is in existing law, there is a right to apply to have your status changed. So this is just adding it to the notice.
I guess my question is better said. Including the posting of excerpts from relevant statutes, did your committee discuss whether or not posting excerpts from relevant statutes or just more plain language information might be helpful to patients? You didn't talk about that?
Did not.
Okay, thank you. That's all.
Okay. So that brings us to section 3. And this is the language that Representative Donahue was referring to with regard to collecting data about emergency and voluntary procedures that may be used on a person, even if they're not under the care and custody of the commissioner, even if they're a voluntary patient. So you'll see this existing language is that the department develops standards for adequate treatment, including requirements that when possible, psychiatric unit staff be used as the primary source to implement seclusion and restraint. And then the new language goes on to say that the department is to oversee and collect information and report on data regarding the use of emergency and voluntary procedures for patients admitted to a psychiatric unit, regardless of whether the patient is in the care and custody of the commissioner, meaning regardless of whether the patient is in an involuntary status. Next, section 4. This looks a little different. It's session law. You're going back and amending session law from 2018. And this particular section had to do with data collection. And at the time, there were 3 pieces of information that were outlined as being collected. And you'll see that the 3rd item is being removed here. And this is, data regarding emergency and voluntary procedures performed in an emergency department on individuals seeking psychiatric care. My understanding is that this piece is being removed because the emergency departments were unable to track this information. And then in subsection B, this is the moving of the sunset that Representative Donahue referred to, so that this report was set to a sunset on January 15th of this year. And instead, the report is to continue for 2 more years. So if you were to pass this, you'd be getting it January 15, 2022 and 2023. And that's it. The effective date is July 1, 2021.
Okay, questions? Senator Hooker.
Thank you, Madam Chair. Representative Donahue, on the patient's ability to ask to have status changed, does that guarantee a change if they choose? Okay, so who?
No, they have the right to apply. It's up to the hospital whether to agree or not. That would be a more complicated change in statute. So this is simply to let them know that they can apply.
Okay, thank you.
Other questions? So I think we'll probably have to ask Vaz about, where is it? The emergency department data collection piece. I assume that's a difficult process, but it would be nice to gather some of that data. No, we've been very concerned about wait times, WAIT, wait times, and wanting to know, what exactly is happening both with voluntary and involuntary patients. So, but it sounds like what happened? What was the testimony there?
Yes, so they did comply to the extent that they were able to gather the raw number and say in the last report, it happened 296 times among all patients waiting in emergency departments, which is about 3%. They were not able to get more detailed, and they describe even that as being extremely burdensome because they don't have it as part of their medical records, because there's a distinction between restraints that are used. For instance, an unconscious patient who's flailing after an accident, that kind of restraint to put an IV in is a different type from a, quote, behavioral restraint, and they don't distinguish. So they had to go by hand. I think, Disability Rights Vermont testified and were very opposed to discontinuing that requirement. And I share in the desire to take it, but I think you should hear from Vaz. I agree. They are committed, they said, to continue to see to find ways to create more ability to know what's happening. There are a lot of problems. There's actually another really key problem with the data that's collected now when we're trying to figure out how long are people waiting because there isn't an inpatient bed versus waiting for outpatient connections. Any data they have where a patient waits in an emergency room to be transferred to another hospital for inpatient care is recorded as outpatient.
Yep.
So
yeah, it's a tip of an iceberg, isn't it? And I think if we had, I hesitate to say this because I know that how hard it is for the hospitals and the ERs, but EDs, but if we had care management for these folks, if we had enough care management for these folks, then we probably wouldn't run into the types of situations that we hear about. So
I think Yeah, I think you're right. One of the things that we discovered, you may recall, Senator Lyons, several years ago, when the first crisis was occurring with emergency department delays, we were getting totally different numbers from the Department of
Yep.
Mental Health and
Yep.
from VAS about how big the backlog was.
Right.
And that turned out to be because DMH was only collecting data for patients in the custody of the commissioner. And there were all
Right.
sorts of other patients also
Lots of
waiting.
other people. Oh, okay. Thank you, Representative Donahue. So I think we will hear from VAS, and I think this might be an area. Katie, is there anything in the bill that asks for an update on how this information might be collected? So number 3 on page 3, A3, is there anything relating to that that asks for an assessment or says written report?
If you're looking for language as to how the hospitals might work to collect that data, that language is not in,
Yep.
in the
Okay,
bill.
that's something I think we're going to want to ask about going forward. It sounds like it's a difficult place. It's a difficult issue, but I think that it's worthy of the conversation. Because if we leave it out, then it suggests that it's not a need. So I'm very concerned about that. All right. Any other questions, committee? All right. Huh.
Thank you very much.
Thank you. Well,
Had a
but
question,
thank you.
but
Will,
I
and
looked at the report, so.
huh?
Sorry, Senator Lyons. I was just saying I had a question about the data, but I was going to ask Representative Donahue, but then I just looked at the report and I found
There it is.
So-
There it is.
I was
Yeah.
wondering how many people are we talking about, and how many Vermonters are impacted by this, and so the report lays that out. So thank you.
I think what we'll do, Senator, is when DMH comes in, we'll ask them to maybe help us go through that report just a little bit and to understand the complexity and the how large the issue is, and just knowing that between that reporting period and now, there's been a lot of upheaval. So we're just getting back to what we need to be looking at. Go
I
ahead.
do have one more question before Representative Donahue goes, because
Sure.
I know you have done so much work in this area and have a lot of expertise. And I'm just wondering if there are other items or issues in mental health that we might consider adding to the bill that this might not cover.
That's kind of a loaded question, but
I know.
I'll give a very honest report.
You have an hour.
Well, I mean, within reason,
quick,
I'm not,
No, it's a quick response without detail, but this was part of a longer bill that probably had, Katie might remember, 5 or 6 other sections that were more significant, maybe some of it more substantive, others more just procedural. As often happens in the legislative process, we were short on time. The pieces that moved forward were the ones where there was not objection from VAS and that DMH was fine with. The pieces that were removed were the ones that would have required extensive testimony because they were not agreeable to all the parties.
Got it. Okay. Not sure if we're going to have time either, but I was just wanting to ask. I can look at the original bill. Thank you.
Okay. Any other questions for Representative Donahue or for Katie McLean? No. Okay. So I think it sounds like right now the bill is approved or agreeable to folks in DMH and VAS, but I think we'll take testimony, a little bit of testimony in particular on that section that has been struck, and try to figure out a way to keep the issue afloat and not totally eliminate it at this point. So, okay. Committee, your thoughts on the bill? Thank you. Thank you, Representative Donahue, very much. Any thoughts, committee? No, we're good.
On
I
this
do,
bill?
A lot of people
you
impacted.
know, I think one of the things I get concerned about whenever we begin to discuss these areas, particularly with the ED, is the case management issue. And of course, then that immediately goes to workforce and access to community services. So this is, there's a lot underlying some of the issues here. Katie, is there anything else we should know about the bill from your perspective at this point?
No, I don't have much to add at this point.
Okay. All right.
Didn't
I
we-
guess go ahead.
I'm sorry, Senator Lyons. I thought we asked DMH to come in today. Did they not? Were they not able to?
They were unable to.
Okay,
They were unable to. So we're rescheduling them.
got it.
Yeah. I forgot when that happened, Nellie. We worked on it together. And I've asked them to come in, not just on the bill, but some other areas of that we might be interested in for mental health. The other area that I guess, Katie, if someone were going to put relevant sections, excerpts from relevant statutes up, and I know it's the underlying language, hasn't been modified in the bill. Do you have a sense of what those relevant excerpts might be? Would it be the Bill of Health, a Bill of Rights, or I can't hear you. Huh?
Can you hear me?
Yes, now we
There
can.
we go. Okay.
Okay.
Maybe I just wasn't speaking loudly enough.
No, you were. It was just, I don't know.
Okay. Including posting of relevant statutes. So for informing patients of their right to discharge and other rights for assisting them in making and requesting requests for discharge. So it is very focused on either discharge or change of status.
Well, I'm just, my question really relates to language that we find in statute versus plain English or other language, plain German, plain French, plain, so I'm wondering is there a way that we could look at those, the right to discharge, where that is in statute? It's not in front of us. Maybe
Yeah,
next time we could look at that.
I'd have to pull it up. And if it's something you're concerned about, you could change the underlying language to say something like summarizing excerpts from relevant statutes instead of posting the specific statutory language. And maybe that would get you closer to a plain language type reading that's a little bit more digestible for people who are looking at it.
Yeah. Senator Hooker.
And then this kind of begs the question about translating it into different languages, as you sort of suggested, Senator Lyons. So, but I think it's important for people to be able to understand, and sometimes statute is not easily understood.
That's exactly what I was thinking. And there could be some timing issues here, so that it might say something like within 30 days of X, or, so does that timeline mean anything to any individual patient? I do not know what we're referring to here in terms of discharge rights, or, do they have to get the physician's approval? So it would be nice to know what's embedded in that phrase and that sentence, and then how to make it clear. Go ahead, Ruth.
Yeah, and is it
Senator-
whatever? Hey, you. Is this posting in ED departments or in mental health facilities or
Hospital.
It's in the hospital, like in hospital rooms. I'm curious, just in practice.
Right, this is a good
I'm just thinking,
question. It could, it could
yeah, I
be,
mean, is it in the hall, in the bathroom? Where is it? I mean, and you know, we just spent a bunch of time on the bill about blah, 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 blah.
right,
the-
stem cells.
Stem
Stem
cell.
cells, that's the one.
Yeah.
Talking about the poster and all that stuff. And
Yeah.
yeah, I can see Anne going, no, please, let's not go there. But the poster, Katie can bring
Wait,
it in.
she
and
wrote the
have a demo.
poster. She's responsible for the 40 size font. So.
That's
Jen's
right, the
responsible.
font,
It's not me.
the color.
sorry.
Oh, that was
No,
Jen's.
Ann.
note,
I was talking about Ann.
Oh.
Senator Cummings, sorry. You're muted, Senator. Probably a good thing. Okay, where were we? Senator Hardy.
It's good to laugh.
I know it is. It's very
feels
healthy.
good.
But-
Let's do it
So,
more.
so the concern about where it's posted.
Well, just sort of in practicality, maybe we can figure out, like, how does it work? How can they see it? Because I agree that, you know, if we're posting statutes, it's, you know, people are not going to understand it or see it. I'm just wondering how they see it and how they understand it, especially if they're in a state of emergency or, you know, concerned or
Have
Yeah.
been in the ER for several days and are restricted to one little section room.
Exactly.
You know, who knows? So.
yeah. So
Okay.
maybe it should be neon or something.
I can't wait to hear from Vaz on this.
Yeah.
Okay. And they're probably listening in, watching in, so they know we're asking the question. That'll be a good discussion. But you do want to make it clear to a patient, regardless of the patient's status. You need to have that. So Katie, if you could help us just understand what those relevant sections are, that's one. And
Yeah.
so that would be really helpful. This
I'm looking
discharge,
through right now and
Okay.
I'm not seeing anything that seems incredibly on point. I'm seeing, oops, that wasn't it. I'm seeing language about notice of hospitalization and discharge. The head of the hospital admitting or discharging an individual shall forthwith make a report thereof to the commissioner and to the court. But I'm not seeing, I'll keep looking.
Well, it could be that it's related to the specific hospital. I don't know. I don't know. We don't know what that says. Relevant statute, though. It doesn't say hospital policy. Huh.
I mean, it could be about discharge if you're on an order of hospitalization and your order expires and it's not renewed, you would be discharged. It could be trying to inform you of that, or that there could be a possible order for continued treatment and what the time frame for that would be. So I'm not sure. I'm not sure how narrowly discharge is being used
Well,
there. But
yeah.
I don't see anything exactly in point kind of governing just discharge itself.
So we don't have any relevant statutes, is what I'm
Oh,
hearing.
hold on. Application for discharge. Here we
Here
go.
we are. Okay.
Let me just pull it up so you can see it.
Okay, great. We could be opening Pandora's box. We don't know.
So patient who has been ordered hospitalized may apply to discharge from the criminal division of the Superior Court within which the hospital is located. And a patient who has been ordered to receive treatment other than hospitalization may apply for discharge to the criminal division of the Superior Court, which originally entered the order. The court, in its discretion, may transfer the matter for the convenience of witnesses or for other reasons to the criminal division of the Superior Court in which the treatment is centered or in which the patient resides. Applications may be made no sooner than 90 days after the issuance of an order of continued treatment, or no sooner than 6 months after the filing of a previous application under this section. And then the hearing on application for discharge shall be held in accordance with various procedures set forth in the chapter or in the title. And then if the court finds that the applicant is not a patient in need of further treatment, it shall order the patient discharged. So I'm sure that this is what that section is referencing. This governs
But this is,
discharge.
so this is for, but involuntary patients, right?
Yes, because if you're a voluntary patient,
Yeah. But it
And-
says, and then it includes switching the patient, the application to have the patient status changed from involuntary to voluntary. Is that,
that's the new
that's
language
the
that's
new
being added.
language?
So that isn't governed here. This is just governing the application for discharge, not for a status change.
But it says in that paragraph, for informing patients of the right or for application to have the patient's status changed. So the application, so information about the application process would have to be posted.
For the status change, yes, and that isn't governed in the statute that I just walked through. That would
That's right.
be in another statute.
Somewhere else. Well, now, if I read that language posted, it would be just as clear as day. Right, April
Which
Fools.
day?
Yeah, okay. So I think,
Like,
yeah,
do
so,
you go to hospitals and interpret that for the thousands of people? This is what it means.
In various
well,
languages.
you know, it does raise the question about having the patient seeing it is one thing, but then also the patient's family or others with the patient. So let's put that on our list to talk about, and we'll ask, and hopefully DMH and VAS and perhaps Disability Rights will be able to inform us a little bit about that. Or not. So Katie, anything else that you discover in your perusal of the statutes would be really helpful.
Okay.
Good. Any other questions, committee, for Katie? Concerns, places you'd like to explore in the bill itself? Just trying to raise questions so when we have folks in to testify, we can be focused. We're good? Excellent. All right, thank you. And so Katie, tomorrow you are coming in on H-171? We'll look
Yes.
forward to that. Okay. So committee, we have some time before 10 o'clock. I think what I'll do just for a couple of minutes, not take long, and then we'll allow some time for a break because it's just such a blizzard outside. We need to take that break today. It's not a blizzard, but it's April showers. So we're going to continue going through the House bills, and then we'll have some discussion time. I believe there's some discussion time in our agenda next week on bills, but we're also going to be, we're under some pressure, obviously. Somewhere within the next 4 or so weeks, this committee will shut down because we're a morning committee. I'm going to try and get some dispensation so that we can complete as much work as we can. We also have an obligation to inform the Appropriations Committee about our recommendations on the budget, and we're going to hear from Stephanie Barrett on the budget. I believe we decided, Nellie, you can help me with this, on Friday. We have Stephanie coming in. And then next week, we'll try to follow up with some discussion with various folks. The one thing that I would ask of you is this. Now, we have taken testimony on the Budget Adjustment Act previously and heard from a number of organizations and individuals who are advocating for some base budget improvements, for some changes to reimbursement process, and some perhaps related policy changes. So you've heard from the DAs, we've heard from DAs, SSAs, we've heard from just a lot of different organizations. And some of us have heard separately. I've heard separately from the Lund Home. We've heard from the parent-child centers, because the request in that bill is a significant budgetary request. And we've heard from Head Start on their needs. We've heard from long-term care facilities on their needs. Most of the needs that we've heard about are related to reimbursement, increased funding. So we are not the Appropriations Committee, yet we also understand the pressures that that these organizations and individuals are under right now. So as we look at the budget tomorrow, we're probably going to see that the House has utilized a significant amount of rescue plan money to fill in, at least temporarily. So it's going to be difficult, I think, for us to set some priorities, because we care very deeply about each of the organizations and groups of people who are represented within our jurisdiction. But what I'm asking of you is to make a list, not just a prioritized list at this point, but just a list of the organizations and the requests that we have heard from and that you may have heard from individually, so that we can have a conversation about those and then make a decision about how we want to go forward and who we may like to hear from. Next Wednesday, we have some time set aside to hear from the primary care physicians. And that I know that Senator Hooker in particular had raised the question about the concern that some of our primary care docs have gone out of practice as a result of COVID. And so we're going to hear from them and going to hear about the issues that have confronted them during COVID, and perhaps, even before. And that will also help in two ways. One, when we hear from the primary care docs, we'll be able to understand a little bit about the workforce issues. And I know, Senator Hooker, you have a bill in on loan repayment and workforce development. And I think primary care is one aspect of that. So we'll hear from them on that. We had put that off from a previous time, so this will allow for us to finish that. And then we're also going to hear, I think I mentioned it yesterday, we'll hear from the NCSL and from the Office of Budget and Planning, a joint meeting with House Human Services on TANF issues. So we'll be able to understand some of the needs and relationships, financial relationships within the TANF programs. So yes, ma'am, and you're muted.
There we go. It might also be helpful to see if Steve Klein could come in and do a 5-minute projection on the revenue forecast. I mean, we've got all this one-time money, but in 2 years, we're back to where we were a year ago.
Yeah.
And just look at what they're projecting. Because that's your base budget. And
yes. Let's do that. I think when Stephanie comes in tomorrow, we can make that request and then we can schedule that in. That's a good suggestion. Okay. Yeah, and we're not the appropriations committee, but honestly, if we recommend every single request that we get, it just passes the buck off to appropriations, and they may not have the same insight into the organizations that we may have. I have a lot of faith in appropriations, but I think we have an obligation to do some of the heavy lifting and making decisions. With no question about it. Senator Hardy.
I was just wondering when the TANF, you did mention it, but I hadn't written it down. When was that happening?
Wednesday.
Next Wednesday?
Next.
Okay.
Yep.
And is that the same day we're talking about primary care and having also Voices for Vermont Children in to speak on something? I can't
That
remember
is
what
Vermont
was.
Voices. The TANF is being coordinated by the Vermont Voices for
I
Kids.
see. Okay.
You got it.
Got it. I
You're
didn't realize that.
absolutely right. Good. And on Wednesday, just FYI, we're going to start at 8:45, and so it'll give us some time between topics to take a little break before we have our joint meeting with Human Services. Then we're also going to be scheduling, I don't remember the full schedule next week, but we'll be coming back to some of the issues that we've been working on. But we're also going to be scheduling in S120 and S232, I forget the number. Anyway, 132? Yeah, thank you. But we're going to try and look at our concept for moving forward on healthcare affordability and accessibility. That's what I'm calling it. Affordability and accessibility, rather than talking about healthcare reform, because I think it loses meaning. So we're going to do that, and we'll be adding in some testimony on that and try to understand what's the information that we need over the summer and fall. How can we gather that data, and then what are some possible provisions we can put in place for immediate action. So my own interest is in trying to eliminate copays for primary care, but that, of course, that has repercussions, budgetary repercussions. But we will try to look at that a little bit. Now I'm going to send you some reports that we've had in the past on some of these issues, so that we can look at those maybe.
Yeah. We tried that in finance last year, I believe.
Yes, you did.
And it's the actuarial balance. And if we cut the cost of primary care, we have to increase the cost of something else.
That's right. And remembering that it's the 1% of the people spending 90%, or whatever the
Yes.
percentages are now, spending 90% of the healthcare dollars. And so you just add the burden onto perhaps those who can least afford it, either end of the spectrum. So, but it would be helpful, Senator. I'm so glad that you're here. It helps.
Keep trying.
Okay, so that's kind of, I just wanted to bring us into a little place of where we are and where we're headed. My other ask of you, in addition to making the list and checking it twice, is to look at the bills that we are going through, the House bills that we're going through, and that will include H-171 tomorrow, and prioritize the bills that you think, A, we could act on most expeditiously, and then B, may take a little longer. We can't promise to the House that we'll pass all of their bills before we adjourn for the session, but at least we can begin to commence to launch off, to go forth on, get some testimony on them. Okay. All right. All right, so I'm going to suggest a stretch, a 12-minute stretch. We'll just, Nellie will go off out of the meeting for about 12 minutes. We'll come back, maybe come back 2 minutes before or a minute before